Good morning, everybody. Thank you for coming. This is our second Dr. Mark Babyatsky Honorary Lectureship Series. We're very lucky to have Dr. Rustgi from UPenn with us. So Dr. Sands, our Burrell Crone Professor of Medicine and Division Chief of Gastroenterology, is going to be introducing Dr. Rustgi and sharing some nice words about Dr. Babyatsky. So if you please give a hand of applause for Dr. Sands.
Thank you. Thanks very much. Thank you all for coming, and thanks to the Department of Medicine for supporting this occasion on the second year. And it's my pleasure to welcome all of you to the second annual Mark Babyatsky, MD Memorial Lecture. And it's really gratifying to see so many of Mark's friends and colleagues, mentors, students, trainees, and his family here to honor Mark. And I want to spend just a few minutes giving you a glimpse of what kind of person Mark Babyatsky was, because not all of you knew him, although I would dare say that many of you, the effects have rippled through time and you have been affected by him, whether you know it or not, if you work here. Some very basic facts. Mark was raised in a really tough neighborhood in the Bronx, but he really rose to the top in everything that he did. He attended the Bronx High School of Science, and then he got his BA from Columbia College, and then went on to Einstein for his MD, and graduated AOA there. And over the ensuing 4 years, he completed his internal medicine residency and chief residency here at Mount Sinai, and his impressive performance was recognized by Drs. Kurt Isselbacher and Daniel Podolsky, who recruited Mark to the GI Fellowship Program at the Gastrointestinal Unit at Massachusetts General Hospital. And after his fellowship, Mark continued at Mass General as a junior faculty member. But then in 1994, Mount Sinai called, and back Mark returned to the Division of Gastroenterology here at Mount Sinai, and he continued his studies on mechanisms of mucosal repair and inflammatory bowel disease in his laboratory. But while he was successful in the laboratory, Mark really found his true calling here as a medical educator. He quickly became one of Mount Sinai's most cherished and distinguished educators and won numerous teaching awards at all levels of the medical school. He was known for mentoring medical students, residents, fellows, postdoctoral scientists, and in 2002, Mark became the program director for the internal medicine residency program, co-program director of the medicine pediatrics residency, and vice chair for education in the Department of Medicine. For the next 8 years, Babs, as he was fondly known by his house staff, nurtured and promoted the careers of more than 400 residents and fellows, the vast majority of whom attribute their success to Mark's personal touch on their lives. His teaching rounds, known affectionately as Babyatsky rounds, were the highlight of the week for all the interns and residents who knew they would walk away with clinical pearls, newfound insights into all types of diseases. And Mark, for his prominence, earned national recognition among internal medicine program directors, and he became the founder and director of the Education Research Consortium of Program Directors and many other distinctions. He was extremely well known as a program director across the country. In 2010, Mark became the chair of the Samuel Bronfman Department of Medicine and professor of medicine at Mount Sinai, and in this capacity, he made an enormous impact on education, research, and all the operational aspects of the Department of Medicine here. And then in early 2014, he assumed new challenges as the chair of medicine at Monmouth Medical Center, where he was developing systems for providing high-quality and cost-effective care. Mark had a photographic memory and a truly encyclopedic knowledge of not only medicine, but also the arts, theater, science, and politics. And if you asked him about a particular movie, unquestionably, he had already not only seen it, he could recount everything about the director, producer, actors, and by the way, he also already read the book, and he would tell you all about it. Mark embodied the keenest of doctoring skills and had an innate ability to mentor and guide trainees. He had an effortless talent for teaching and an enviable and incredibly accessible body of knowledge for medicine and for life. And what really distinguished Mark from so many other gifted scholars and educators in medicine was his deep caring and his compassionate personality, his truly genuine interest in every person he met, from student, resident, and fellow to patient, family, or friend. Everyone who knew Mark felt as though they had a unique and close personal connection to him. He made everyone feel valued and important. Whenever you met him, his first words were inevitably, "And how are you?" And this was never less than a heartfelt expression of his concern. And I can just still hear that in his voice, slightly gravelly, that "how are you?" He exuded optimism, warm humor, friendliness to everyone in all walks of life. In this way, he affected so many lives in countless ways that maybe he never fully appreciated or knew. And I know that Mark had a profound impact on me at very critical junctures of my life and career, and I know that I'm not alone in that. We are really all the better for having had him among us, and we miss him deeply, and it's wonderful that we can gather here every year to honor his memory. And so now, in his memory, in Mark's memory, it's my distinct pleasure to introduce the second annual Mark Babyatsky Lecturer, my friend and colleague, Dr. Anil Rustgi. Dr. Rustgi is the T. Grier Miller Professor of Medicine and Genetics and Chief of the Division of Gastroenterology at the University of Pennsylvania Perlman School of Medicine. He received his undergraduate degree summa cum laude from Yale, and then his medical school was at Duke, followed by medicine residency and chief residency at Beth Israel in Boston. After completing his GI fellowship at Massachusetts General Hospital, he joined the faculty of Harvard Medical School and Mass General and launched his career as a renowned physician scientist focused on GI cancer. In 1998, he moved to Penn to become the division chief, where he's been ever since. Anil has been continuously funded for his work in GI cancers by multiple NIH grants, including R01, center grants, and training grants. He's a member of prestigious organizations such as the American Society for Clinical Investigation and the Association of American Physicians. He's been president of the American Gastroenterological Association and editor-in-chief of Gastroenterology, which is our field's most impactful journal. Anil has also been the recipient of numerous mentoring awards, including, and has also been awarded the Julius M. Friedenwald Medal, which is the highest award in gastroenterology. Anil has trained dozens of successful academic gastroenterologists. He has published well over 200 original papers in basic and translational GI oncology. In short, he is a luminary not just in GI, but in medicine, but also, equally importantly, like Mark, he is a mensch, and he knows the meaning of those words, having worked at Beth Israel long enough and having known Mark long enough. Anil was a dear friend of Mark Babyatsky's, and so it is entirely fitting that he be chosen as the second annual Mark Babyatsky, MD, Memorial Lecturer. Please join me in welcoming Dr. Anil Rustgi and congratulating him.
Thank you for those most generous words, but I'd like to turn that to thank Mark's family, Liz, Linda, and Sheldon, for being here. This is all to honor Mark and have fond memories of him. And also, special thanks to the Department of Medicine under Dr. Murphy and the GI Division, Dr. Sands, Dr. Itzkowitz, and I really enjoyed my meetings yesterday and especially with the fellows this morning. So for some of you, this talk may be quite simplistic and boring, so you're welcome to leave at this point. And for those of you who remain, I hope I can convey some exciting information about pancreatic cancer. So the talk is divided into three parts. The first is the hereditary basis of pancreatic cancer. I'll probably spend a little bit more time of that in a disproportionate fashion. And then opportunities that are emerging but have not come to fruition for early detection in hereditary pancreatic cancer and the more common sporadic pancreatic cancer. I'll give two illustrations of that, certainly not all the illustrations. And then I'll end on a perspective and on the excitement in therapy of sporadic pancreatic cancer, lessons from hereditary pancreatic cancer and other types of approaches that target pancreatic cancer cells. And As Mark's family knows, Mark's and Linda's mom passed away from pancreatic cancer at age 76, and being a Holocaust survivor, it's hard to know in Mark's family if there was an extended family history of pancreatic cancer and other cancers. So when I think about cancer in a very broad sense, to subtype it into two formats or two subplots. One is that there's some change, typically a genetic alteration that's heritable at the germline level or constitutional. Admittedly, this is a subset of all cancers, but it has had great impact upon our understanding of sporadic cancer, which is age-related and involves complex interplay, more so of environmental and lifestyle factors, but there may be certain risk alleles that predispose to sporadic cancer that then have a complex interplay with these environmental and lifestyle factors. And this is seemingly occurring in a stochastic or random fashion. This is the majority of cancers, the majority of disease. So if we think about a couple of examples of cancers that are more at the heritable or inherited level, these would be like childhood retinoblastoma, childhood Wilms tumor. Those that are more sporadic would be breast cancer and colon cancer, and we had a great lecture last year by Dr. Itzkowitz on colon cancer. But there's a subset of breast cancer and colon cancer that's heritable that's really provided great insights into the sporadic counterparts. And that's what I'd like to convey is what lessons we can learn from hereditary pancreatic cancer that are applicable to sporadic pancreatic cancer. So if we look at pancreatic cancer, there are several subtypes. 95% is due to pancreatic ductal adenocarcinoma or PDAC, and I'll use these terms interchangeably, but when I say pancreatic cancer, it's really targeting pancreatic ductal adenocarcinoma. The remaining 5% that I won't have a time to delve into are neuroendocrine tumors, and very rarely Aster cell carcinomas, lymphomas, and sarcomas. So tissue biopsy is still important, even if clinically it's reminiscent of pancreatic ductal adenocarcinoma. Gloria Peterson at Mayo Clinic has estimated that 5 to 10% of pancreatic cancer is hereditary with high penetrance at 80%, and the remaining is sporadic. A little bit about epidemiology. Much of this you know already. It's amongst the top 10 most common cancers, over 55,000 cases every year. Fourth leading cause of cancer mortality, unfortunately, and it's projected by 2020 to be the second leading cause of cancer-related mortality. It is age-related in the sporadic counterpart with mean age and median age about 67 or 68. So you can see these histograms showing increase in over age. And unfortunately, most patients present with nonspecific symptoms that don't necessarily merit further evaluation or deep evaluation. And as a result, the preponderance of patients present with manifestations of metastatic disease, especially the peritoneal cavity, liver, and lung. So it's only a small set, maybe 9%, 10% at most, that present with localized disease that's amenable to surgical resection. So the overall 5-year survival of pancreatic cancer is now up to 7%, which in the field is a lot. But those that are surgically resectable in high volume centers such as here, the 5-year survival's 20 to 25%, but that's a minority of the patients. So we really have to emphasize early detection to try to push patients into surgical resection in spite of the advances that are made for therapy of metastatic disease. So again, 5-year survival overall is 7%. Number of new cases are increasing every year. Unfortunately, mortality is matching incidence, and you don't see this type of scenario with most cancers. So let's talk about hereditary pancreatic cancer. There's been an explosion of information about hereditary GI cancers in general, and again, Dr. Itzkowitz alluded to the colon cancer syndromes last year, so I won't belabor it. But that sort of same approach is evident in pancreatic cancer. And studies from Johns Hopkins have revealed that if one is without pancreatic cancer but has a first-degree relative, the risk of pancreatic cancer in oneself is perhaps minimally increased, but not substantially. That risk really substantially increases if there are 2 first-degree relatives, more than 6-fold increase, and if there are 3 first-degree relatives, over a 30-fold increase. So like Dr. Lucas and Dr. Itzkowitz has here, we have a really comprehensive GI cancer genetics program, and this is a typical family. This woman came to us in good health with 2 brothers. Her mom passed away from, her father passed away from pancreatic cancer, a paternal uncle from pancreatic cancer, paternal cousin with pancreatic cancer, early onset. And actually there's a history of disparate cancers on the maternal side. So she asked, well, what is my risk? What should I do? Here's another family. This patient came to us with a sibling with a neuroendocrine tumor, islet cell tumor, a father, a paternal grandfather with definitive pancreatic cancer, and a paternal great-grandfather possibly with pancreatic cancer. What to do? I'll come back to these. So let's go through, in a descriptive fashion, forms of hereditary pancreatic cancer that you may encounter directly in your practice or indirectly in consultation. So the first one, often in collaboration with our dermatology colleagues, is called Familial Atypical Multiple Mole and Melanoma, and I'll abbreviate that as FAM. So clinically, these are individuals with, and families with malignant melanoma and 1 or more first and second degree relatives. A lot of nevi, over 50, and you can see these spread throughout the torso. And if you biopsy these nevi, they'll have sort of disrupted architectural features and a lot of infiltrating lymphocytes. So it's a combination of atypical moles and melanoma. But these patients will also have pancreatic cancer. Seems sort of odd to be selecting 2 disparate cancers. Well, the genetic basis has been defined for over 20 years, and I'm not going to belabor or bore you with features of the cell cycle, except to say that at the germline level, important components of the cell cycle are mutated to lead to melanoma and pancreatic cancer, in particular P16 and also CDK4, CDK6. So leaving that aside, those are the genes to focus in on. But these families present with pancreatic cancer very early in life, sometimes in their 20s and 30s, and we have a number of these pedigrees. And the lifetime risk of pancreatic cancer is on the order of 20-fold. Almost 20% will have pancreatic cancer by age 75, and almost all patients will have melanoma, those who have them by age 80. So it's recommended for genetic testing and counseling and screening if the family has more than 2 melanomas, 1 member with multiple melanomas, and pancreatic cancer. And it's been shown that if patients are confronted with the knowledge that they have FAM, and even if their pancreas is free of disease, that they will opt for prophylactic pancreatectomy in order to avoid problems. The second one is called Yeager syndrome. This is mostly in the pediatric and adolescent young adulthood population. These are patients that have small intestinal and or colonic polyps that can develop into adenocarcinoma in those sites. They can have polyps and cancer in other sites. These patients on physical exam have mucocutaneous pigmentation on the dorsal surfaces of their hands, and eventually during adolescence around the lips and the buccal mucosa or in the nasolabial folds around the eyes. This is quite distinctive and can be recognized even from a far distance because it's so dramatic. So these patients are predisposed to GI polyps, mucocutaneous pigmentation, but also a whole host of other cancers, lung, cervical, and especially pancreatic. So the genetic basis of this syndrome has been defined, and it's due to something called LKB1, and view this as a master conductor of metabolism and protein synthesis. So if it's mutated, the cell receives cues or miscues to proliferate and grow more, and there's tissue growth. These patients have a whopping increased risk of pancreatic cancer of 130-fold, not only adenocarcinoma, but cystic neoplasms and biliary neoplasms as well. So it's recommended for pancreatic screening in these individuals actually start at age 30, and I'll come back to that a little bit later. Lynch syndrome, again, a syndrome with which you're quite familiar through Drs. Itzkowitz and Lucas, and I'm not going to belabor it too much, and I'll come back to this in the therapeutic section, is that defects in DNA replication are constantly occurring, and there's a whole machinery involving these genes and encoded proteins to repair DNA and maintain the fidelity of DNA replication to daughter cells and subsequent generations of cells. And if one of these genes is mutated, this leads to something called microsatellite instability. I'll come back to that towards the end. And so about 2/3 of these patients have a predilection for mutations in MLH1 and MSH2. And there's some literature to suggest these patients, apart from having an increased risk of colon cancer and other cancers, might have increased risk of pancreatic cancer 2 to 4-fold. I would say in our population at Penn, we're not seeing this, but we certainly respect this reporting in the literature. So these patients are autosomal dominant and increased risk for colon cancer, endometrial cancer, and a variety of other cancers. Hereditary pancreatitis is typically these patients would present with recurrent acute pancreatitis before the age of 10 and definitively before the age of 30 based on consortia studies in Europe and in the United States. So they have the typical manifestations of acute pancreatitis, and the recurrent acute pancreatitis then progresses to chronic pancreatitis, where they then have complications of exocrine insufficiency with fat malabsorption and endocrine insufficiency because the scarring process now then starts to hit the islet cells. Aggravating factors include alcohol and cigarette smoking acting in synergy. It's autosomal dominant, as are all the conditions I've mentioned, highly penetrant, and a 35-fold increased risk of pancreatic cancer, especially those that continue to smoke cigarettes. So if you look at sporadic pancreatic cancer, the biggest risk factor is chronic pancreatitis, idiopathic, and within that, it's the conspiracy between alcohol and cigarette smoking that leads to recurrent acute pancreatitis and chronic pancreatitis. So this models actually the inflammatory microenvironment in chronic idiopathic pancreatitis in the general population. So the genetic basis for hereditary pancreatitis was defined over 20 years ago. And by way of a brief reminder about pancreatic physiology, that trypsinogen, a proenzyme, is converted into trypsin that's secreted through the pancreatic ductal fluid into the duodenum to help with cleavage of certain amino acids. So if you have a mutation in trypsinogen, or the gene is called PRSS1, you get constitutive activation of trypsinogen, and it sort of deceives the Astner cells and causes a lot of injury and Astner cell death, all the histologic features of pancreatitis. And so these patients, we have a fair number, especially transitioning from Children's Hospital to our adult side. And rare mutations have been described in other genes. I won't belabor them, but the carry-home message would be they all have a direct or indirect impact on trypsinogen, and the outcome of all this is activation, almost permanent activation of trypsinogen. And the cumulative risk of pancreatic cancer in patients with hereditary pancreatitis increases in age, but it does start earlier in life based upon this analysis by Al Lowenfels. Perhaps the most appreciated or recognized cause of hereditary pancreatic cancer are germline mutations in either BRCA1 and more preferably in BRCA2, and that may have to do with that the levels of BRCA2 are higher than BRCA1 in pancreas tissue. So these are genes that suppress growth. They're big genes, different chromosomes, autosomal dominant, and I'll come back to this. Again, each one of us in our cells has spontaneous breaks in double-stranded DNA, and there's a recruitment of a whole village of proteins to repair these breaks. These breaks occur spontaneously or through exposure to chemical carcinogens or UV light. And amongst these key village of proteins are BRCA1 and BRCA2, so they can be mutated, along with occasionally ATM and PALB2. And so this disrupts repair mechanisms and is then transferred on to future generations of cells, creating havoc, basically. So DNA can also undergo damage in causing what's called single-stranded breaks, not double-stranded breaks. And there's a whole different host of proteins involving ribose polymerase, or PARP, that affects the recruitment of other proteins to repair these single-stranded breaks. Parp inhibition allows a cell to avoid repair of single-stranded breaks and basically then incur double-stranded breaks. So basically, a cancer cell wants to undergo repair of single-stranded breaks, but by pivoting from single-stranded breaks to double-stranded breaks, a cancer cell becomes much more susceptible to death. So if a cancer cell has one copy of a mutation in either BRCA1 or BRCA2, there's still normal function in the remaining copy of BRCA1 or BRCA2. And if one treats with an agent like a Parp inhibitor, that tumor cell is resistant to that therapy. However, if you lose the other copy of BRCA1 or BRCA2 and then come in with a Parp inhibitor, it undergoes a process called synthetic lethality, and then this tumor cell is sensitive to the Parp inhibitor. I'll come back to that a little bit more if that didn't make sense. And so a lot of studies have shown, including international consortia studies, that pancreatic cancer risk is on the order of 3.5-fold relative risk in BRCA2 mutation carriers, and amidst a spectrum of other cancers as well. Obviously, the most common would be breast and ovarian. And then in BRCA1 mutations and non-breast cancer risk for pancreatic cancer, the relative risk is 2.8. So there is a signal for pancreatic cancer, whether one has a BRCA1 or a BRCA2 mutation. So we come back to the two pedigrees that I mentioned. In this case, the families of Ashkenazi Jewish descent, and this patient had a germline BRCA2 mutation, tested her brothers, one of them has a BRCA2 mutation, so that brother's at increased risk for prostate cancer and male breast cancer and pancreas cancer. She's at increased risk for breast and ovarian and pancreatic cancer. So they're undergoing screening, and she's had prophylactic surgery as well. Come to pedigree number 2. As is done here, we do a gene panel looking for all possibilities, about 20 to 25 genes for hereditary pancreatic cancer. And we didn't find any gene that's mutated, so the gene panel was informative. But nonetheless, one would argue there's an increased risk in this patient and what to do in that context from a clinical viewpoint. So with that in mind, what are the opportunities for potential early detection in hereditary and sporadic pancreatic cancer? Because if the vast majority of patients are presenting with metastatic disease, and even though there have been improvements in therapy, we're sort of behind the 8 ball. So I'll give you 2 illustrations. One is a study involving multiple centers, including our own, and that's called CAPS-5 for pancreatic cancer screening. Its 5th iteration. This was initially funded through the American Association of Cancer Research and now through the NCI. And the multiple centers have certain criteria for entrance of patients into this, which really involves grouping them based upon whether they have a gene mutation, like I mentioned with Yeager's, or with FAM, or with breast cancer genes, or a certain family history, 2 or more kindreds with pancreatic cancer, and at least 2 are first-degree relatives. And we have other groups with a Lynch mutation or mutations in hereditary pancreatitis. or finally where pancreatic cancer is suspected or known and meets inclusion for groups 1 and 5. So with these relatively strict criteria, but at the same time trying to cast as broad a net as possible, these individuals starting at age 50, except for Yeager starting at age 30, undergo annual screening, which is center dependent. It can either be, at our center we do annual endoscopic ultrasound, at other centers annual MRI, at some centers alternating between the two. Blood is stored with plasma for the possibility of biomarker discovery. Across all the sites now, over 1,500 patients have been recruited, enrolled, and are being monitored through imaging. At our center, on the order of about 110 patients, and they're also control patients. So this is exciting because we need to have some sort of descriptive analysis to understand the potential efficacy of non-invasive or minimally invasive screening. And it's really hard to do general population studies because the incidence isn't high enough to screen the general population. So right now the strategy is to screen potentially screen at-risk or high-risk patients. So how to screen? I mentioned endoscopic, ultrasound, or MRI. They're equivalent. Perhaps EUS is superior, and EUS offers the opportunity that if asymptomatic lesions are picked up, then detected, then you can do aspiration or biopsy. And we have protocols now to do deep sequencing on minimal DNA. Spiral CT can be done, although not as advocated as much. Right now, our CAPS-5 study initially proposed doing it every year for 5 years, but we've extended that, and now patients are being screened for 8 years. I'll say anecdotally, out of our 110 patients that have been recruited and enrolled, 5 have been detected, again, without symptoms, with pancreatic lesions and have undergone surgical resection. And there's a great desire to find biomarkers in the pancreatic ductal fluid, as well as in the serum or plasma, or in lymphocytes that's DNA-based, RNA-based, or circulating tumor cells. This remains investigational at the current moment. We also have a protocol for our patients who have gene mutations that are heritable in one of these breast cancer genes, but they don't necessarily have a history of pancreatic cancer. So my colleagues in breast cancer genetics have close to 2,000 patients with one of these mutations, mostly BRCA1 or 2. And so it's sort of a pseudo CAPS-5 where we're screening them on an annual basis and storing blood on an annual basis for biomarker discovery. So this is to answer the question, is it meritorious to do screening, especially in BRCA1 or 2 carriers, if they don't have a family history of pancreatic cancer? And this is a report from Johns Hopkins, a 74-year-old woman, 2 first-degree relatives with pancreatic cancer. Imaging suggested IPMN, a pancreatic cystic lesion. It was confirmed by EUS. She underwent a Whipple resection and was found to have high-grade dysplasia but no overt tumors. So this is what we'd like to do, is detect things early at a precancerous level or at a stage 1 level, if at all possible. Let me shift gears within early detection to an illustration of biomarker discoveries for sporadic pancreatic cancer. This is done by Dr. Ken Zaret and colleagues at Penn's Institute for Regenerative Medicine. So they'll take from the surgical OR, they'll get a piece of the pancreatic tissue, manipulate it with certain genes, the so-called Yamanaka factors, and convert the identity of these pancreatic cancer cells into stem cells, put them into mice, and then these mice start to develop pre-neoplastic pancreatic lesions, so-called Pannin lesions in pancreatic cancer, just like it would look histologically to the human pathologist. And so then they've taken the mice at different stages and collected blood for biomarker discovery. And what they've been doing is basically following the NCI protocol for biomarker discovery, going through different phases, discovery, validation, and a second validation. And from this, in human patients with pancreatic cancer, with appropriate controls, with normal pancreas, pancreatic cysts, and chronic pancreatitis, they've discovered that a protein called thrombospondin 2 is elevated in sporadic pancreatic cancer. And with that in mind, the conventional approach is to use CA19-9, but it suffers from not great sensitivity and specificity. And what they found is that if you combine thrombospondin 2 with CA19-9, this has a C statistic of 0.96. So we're very excited what they're doing here, and a lot of studies are ongoing to look at not only patients who are about to undergo surgery, but then follow them longitudinal after surgery. If thrombospondin 2 with or without CA19 is elevated, does it come down after surgery, and does it recur over time? And also in our CAPS-5 patients, we're trying to see if thrombospondin 2 might be an extremely early biomarker of disease in these individuals. So this type of approach, based upon basic science principles, has the potential to have impact in early detection. And probably I suspect that a panel of proteins is needed, but this is sort of one important illustration of that approach. Let me now go into the third part, in approaches to therapy of sporadic pancreatic cancer. As many of you know, the outcomes for patients with neuroendocrine tumors after surgical resection is quite good and acceptable. A little bit worse in patients who have cystic adenocarcinoma from pancreatic cystic lesions, and not good, as I alluded to at the outset, with ductal adenocarcinoma. So what can we do? First and foremost is based upon the rich experience of medical oncology colleagues, was in the late 90s, followed by FDA approval with gemcitabine, a nucleoside analog disrupting DNA. But this published in about 7 years ago revealed the superiority of FOLFIRINOX, which includes oxaliplatin, irinotecan, leucovorin, and 5-FU, improved over gemcitabine alone, overall survival of 11.1 months, progression-free survival of 6.4 months. So this is FDA approved for metastatic pancreatic ductal adenocarcinoma, and perhaps there's a preference for this in a number of European centers. It's not without its side effect profile, including neutropenia, thrombocytopenia, and a variety of other symptoms and signs that are listed here. So it's not free of side effects by any means. Further progress was made with the conjugation of one of the taxols, plaxitaxel, with albumin, allowing it to remain in circulation for longer periods of time, and then delivery in pancreatic cancer tissue and remaining there for longer periods of time. So a lot of mechanism has been worked out on how this works in terms of cell killing. And this really culminated in this important and landmark study published 5 years ago, led by Daniel von Hoff, showing that Abraxane with gemcitabine was superior to gemcitabine alone, with a median survival improving from 6.7 months to 8.5 months, and a progression-free survival improving from 3.7 to 5.5 months. So the vast majority of our patients with metastatic disease, first-line therapy will be one of these two. Nonetheless, there's a great promise with Abraxane and gemcitabine. I would say in most US-based centers, this is what is pursued. And you can see improved hazard ratios for a number of subgroup variables. It is with some side effect profile, hematologic, as well as diarrhea and peripheral neuropathy, so one has to keep this in mind. So treatment algorithms speared by NCCN guidelines, metastatic disease. I think it is important to confirm the tissue diagnosis. And with that in mind, I'm not going to belabor it. a variety of different approaches for adjuvant therapy, locally advanced unresectable disease. One of the notions is to try to downstage locally advanced unresectable disease, perhaps with neoadjuvant chemoradiation therapy, followed by resection. And the two pivotal trials that I just mentioned are for metastatic disease. So this makes a lot of sense because it's founded upon principles of chemotherapy for the last 40 years. But I would say in the last few years and well into the next decade is a revolution that's ongoing for different types of approaches and different types of therapeutics on top of the systemic chemotherapy. First and foremost, as is being done here as well, is immunotherapy, either with immune checkpoint inhibitors. This is quite common now in melanoma, small cell lung cancer, kidney cancer. At our institution, initial forays into CAR T therapy as well as vaccine therapy, combination of radiation therapy plus immunotherapy because of radiation therapy is able to suppress resistance mechanisms that emerge with immunotherapy. A whole effort at NCI to target mutant KRAS because that's found in almost 100% of pancreatic cancer. And a phase 3 trial that should have results by early calendar year 2019 is to modify the tumor stroma so that essentially trying to dissolve it to allow for better delivery of agents that are used conventionally. So maybe the agents aren't so bad, but they're not reaching their targeted tumor cell site. So this hyaluronidase that's pegylated then will sit in the tumor microenvironment, dissolve the dense stroma, and the current trial is to compare gem-Abraxane plus minus PEG hyaluronidase. So phase 2 studies were quite encouraging. Phase 3 results we should have next year. And at our institution, Gregory Beatty is leading a clinical trial to use a CD40 agonist in combination with gemcitabine in unresectable PDAC, which really promotes the tumor suppressive actions of macrophages and allows T cells to penetrate the environment. So this study is ongoing. And so these are anecdotal reports of CD40 agonist with gemcitabine. You can see this patient with a large metastatic lesions to the liver with treatment. You can see essentially, at least by imaging, dissolution, but then off therapy recurrence. So it's exciting as a way to induce the activity of tumor-killing macrophages. If we go back to principles and insights from hereditary pancreatic cancer, how can we apply that to therapy of sporadic pancreatic cancer? And two examples come to mind. One is that 1% of all pancreatic cancer have microsatellite instability high status. Immunotherapy in this context is approved for metastatic colon cancers and colon cancers metastatic with Lynch syndrome with immune checkpoint inhibitors. So 1% of cases of pancreatic cancer are genotyped for microsatellite or immunohistochemical staining for microsatellite instability status, and these patients are eventually going on immune checkpoint inhibitors. And then, as I mentioned, those patients that have BRCA2 or BRCA1 mutations at the germline or at the sporadic level then have opportunities through clinical trials from hopeful improved outcomes with DNA cross-linking agents. I mentioned Parp inhibitors, switching or pivoting the tumor from single-stranded breaks to double-stranded breaks and using the principles of synthetic lethality. And the platinum drugs actually seem to lead to better response when patients have BRCA1 or 2 mutations. So at our institutions, there's a trial ongoing for point of care. At the time of the diagnosis with pancreatic cancer, to do immediate checking for these genes and other genes to see if there are mutations, and then to enroll them in FOLFIRINOX. So I will conclude there, and some comments. This is Mark. This is Dr. David Jaffe, who was here for 10 years. I think maybe Dr. Weiss knows who this staff member was. David told me that she's retired. In this picture, David had a lot of hair, and you can only guess the outcome. And here's Mark as a really cool guy. And so we had this thing, and Dr. Sands alluded to it, that Mark was an aficionado of everything, theater, movies and books. And so a small cohort of us, not too bright, except for Mark, each year from 1991 on would have a betting pool, sort of like the NCAA pool, except it didn't receive that much publicity, is who could guess the Oscars for Best Movie, Best Director, Best Actor, Best Actress. So Mark actually won this. And he running champion for over 20 years. And I don't think this record will be matched in the future. And I will say, Mark would never admit it. There were a few years that we didn't have the betting, but he still won. And so with that in mind, I thank you. Mark, many of us might have a few of these features, but only a few have all these features that are listed here. And no doubt Mark stood tall and remains tall, and I, like many of you, will continue to carry on his legacy. So thank you for the honor of being here. What an incredibly wonderful talk. And in remembrance of your time here, we have for you this award that commemorates you as the second annual Mark Babyatsky Memorial Lecture. So thank you very much. And you're so brief in your talk, we do have lots of time for questions. So I hope you'll take some questions. Absolutely, I'll try. Right.
Yes.
Nice presentation, and probably in heaven, Dr. Babyatsky was very pleased to hear your opinion.
Absolutely.
I have a question. Could you venture a guess as to why in an illness like this, pancreatic cancer, where age is such a dominant player? My question is not about old people, it's about biology of aging cells, the aging of cells.
Yeah.
Why is there so little attention to the Hayflick phenomenon? Who knows what insight that would give us about this?
Yeah. So I think the question relates to aging and disease, and cancer being one illustration of that. A lot of changes are occurring that all of you know with aging at a cellular level and a tissue level. Epigenetic, the accumulation of somatic mutations, not germline. And I would say third is probably an attrition of stem cells with aging. Many tissues demonstrate evidence of that. So probably all these factors then create an environment for a switch from a normal state to a precancerous state and eventually a cancerous state. And these are hard things to combat because the good news about medicine is our patients are living longer, but now they're predisposed to these factors. So I'd say a fair number of studies are revealing a lot of perturbations going on, as you might imagine, in aging cell. But I think one of the big ones is an attrition in stem cells, so there isn't the opportunity for renewal of differentiated cells and impaired tissue regeneration. Well, we should also keep in mind, and it's a different point, that in the lifespan of the human, most cells remain normal, most tissues remain normal. But there's a subset that develop precancerous lesions as well, and those precancerous lesions might exist in humans for years, if not decades. So it's probably those precancerous cells that remain dormant over time, but then certain events occur to convert that precancerous lesion into a cancerous lesion. And that's one of the compelling reasons, of course, to do screening and surveillance, either in age-dependent fashion or, like in this case, at-risk patients.
We have a question in the very back.
Claire Dallin for Geriatrics. I have a question that sort of relates to that one. So if the average age of sporadic pancreatic cancer is 68 years old, has there been thought to sort of, taking a meaningful interval around that age and sort of figuring out what therapies work in that setting? And I'm curious about that.
From a therapy, not from a screening viewpoint.
From a therapy.
Yeah, so the therapeutic approaches in clinical trials are agnostic to age. There may be some cutoffs if the patient is old and has comorbid illnesses, of course, but I'm not aware of anything that's necessarily focusing on a certain age group because of the wide range of ages in which patients are presenting. So I don't know if I answered your question, but there's no narrow window of therapeutic opportunity that I'm aware of.
Yeah, I noticed on your slide that one of the cutoffs was 65 years old and younger, and then 65 and older. And sort of the outcomes of those two, one kind of crossed the midline, which was the older
Yeah.
patient. So that's why I was curious.
Yeah.
Question from Dr. Kohler up front.
Thank you for this beautiful presentation and the tribute. Fanconi genes were
Yeah.
not on your list.
Yeah,
And
they should be, yeah.
so the question is there something to be learned from
Yeah.
the relative predisposition through the Fanconi repair pathway?
Yeah, so two answers to that. One is that at Johns Hopkins published about 3 years ago, they took a look at over 600 patients with familial pancreatic cancer and said, okay, let's and sequence the genomes and say, you know, are there other genes besides BRCA1, 2, PALB2, ATM, and CHEK2? And surprisingly, there weren't that many additional genes, maybe 10, but the mutations in those additional 10 or so were quite rare. And I would say, as I look at it, they fall into two classes. One is cell cycle, and the other is DNA repair. But in those, rarely the mutations were found in Fanconi's genes. So there's something about defects in DNA repair that are fostering pancreatic cancer. And I think from a therapeutic viewpoint, therein lies opportunity, probably in combination with immunotherapy. To my limited understanding, patients with Fanconi's anemia are at risk for lymphoma, head and neck, squamous.
Yeah, peculiar distribution.
Head and neck
Obviously, bone marrow
squamous.
failure, leukemia, but head and neck.
Squamous.
So
And anecdotally, maybe pancreatic cancer, but there just aren't enough patients to know. But at the germline level, it's been reported.
and they may not live long enough to get it.
That's true. Do they mostly die from bone marrow failure? Yeah.
Steve.
Anil, you really did Mark proud. Thank you so much. A question about thrombospondin. CA19-9 is a carbohydrate antigen on mucin glycoproteins, and it kind of makes sense, you know, all right, pancreas, mucin. What do we know about the role of, you know, the biology of thrombospondin? Mechanistically, what do you think might be going on in terms of pancreatic cancer?
Just guessing on my part. The thrombospondins, amongst other functions, are involved in angiogenesis, neoangiogenesis, so it's quite possible that amidst the dense stroma of pancreatic cancer, there is neoangiogenesis, so maybe that's playing a role, and thrombospondin might be upstream. The other thing is thrombospondin is a regulator of c-MYC, and that's up as well. So I think mechanistically, probably related to MYC and possibly to neoangiogenesis. There are some other proteins in their hits, so what they're doing is now going and looking at those, and they got, through Gloria Peterson, all well-annotated controls, so now they're going to start looking through ELISAs at various combinations of those biomarkers. I think doable.
Great. One last question.
Yeah. You mentioned a lot about the causes of this and the changes over time in pancreatic cancer. And going back 30 or 40 years, I mean, this was really unheard of, pancreatic cancer.
Yeah.
And there seems to, at least in my experience, seems to be
Yeah.
a major increase. So I wonder, are there any environmental factors?
Yeah.
What's just basic, you know, environmental epidemiologic look?
Yeah, it's a great question. You know, I think some of it is detection bias. Some of it is aging. If, you know, when you see that incidence, if it's, I think those two are major factors. Is there an environmental factor, as has been suspected, say with sporadic breast cancer? Hard to know. I suppose some of it may be indirectly diet related, since changes in central adiposity have been linked. And you can imagine secretion of cytokines and chemokines that are pro-tumorigenic. So, you know, in spite of the fact that the disease leads to cachexia, possibly obesity may be related, and that would fit in what you're suggesting in a narrow window of 10, 20 years that could lead to an increase. So that, I don't know. Amy, do you have thoughts on that?
We looked at worldwide trends in onset of pancreatic cancer and incidence of pancreatic cancer, and we seem to see some parallels with obesity worldwide, but there's concerns about diet and tobacco use as well.
Last question.
For somebody that screens positive, a family member of somebody with breast cancer, male with BRCA positive, who is HIV positive but otherwise fine, at what age will you start screening, and how will you screen for pancreatic cancer?
So if I understood correctly, male patient, BRCA2,
Yes.
and no family history?
The family history is of breast cancer, not pancreas.
Yeah, so I don't think that patient, if I understood, would be eligible for CAPS-5, but we have a pseudo non-CAPS-5 study where we're trying to enroll all of our BRCA1, BRCA2 as if they were part of CAPS-5. So under Amy, you could see, you know, if imaging should be done, and if it is, what should be done. So that's how I would pursue it. And certainly, to the extent possible, screening for prostate cancer. Okay, thank you.
Anil, thanks very much.